ever MCEDA webinar. My name is Leslie Kiesel, and I work in marketing here at MCEDA. And this is the beginning of a monthly webinar series that we're going to be continuing throughout 2014. Just to cover a few items of housekeeping here. Of course, we'll be talking about all things Stage 2 coming up. All lines will be muted throughout the whole webinar, so we encourage you to send questions possible that we can on the call today. But if for some reason we don't get to all of your questions, we will be posting question and answers online, and we can also email you individually to make sure that your question is answered. Our speaker today is Bruce Mackey. He is an incentive program analyst here at MCEDA, and he brings a wealth of experience both from the IT side of things and being a practice manager in the field. So we also have Judy Varela as a panelist with us to help answer questions. She's one of our regional managers. And with that, we will hand it over to Bruce to get this presentation started.
Thank you, Leslie, and thank you to everyone who has dialed in to attend this first in a new monthly webinar series from MCEDA. As Leslie mentioned, my name is Bruce Mackey, and I am MCEDA's Regulatory and Incentive Program Analyst. Today, I will be giving you an overview of meaningful use. We'll be talking a little more in-depth about the Stage 2 final rule, some of those summaries of objectives and measures for eligible professionals. We're going to talk a little bit about the payment adjustments and audits. So if you're a Medicare provider and are not a meaningful user, what does that mean? As well as the audits that are undergoing at both the federal and state level on the meaningful use program. We will be talking a little bit about the MCEDA program overview. I know we have a nice mix of people dialing in today who are both MCEDA clients and non-MCEDA clients, and so we want to touch a little bit about the MCEDA program as well. And I think for those of you who are MCEDA clients, you might find out a little more information about some of the services that we provide as well. We will then end with some question and answer session. If you'd like to, throughout the program, if you have a question, we're going to keep the lines muted. But if you'd like to submit a question, please submit that through the question function in the webinar interface. Go ahead and type that in. We'll be looking at those as they come in. So Judy's here to help out with the questions. And if for any reason we are not able to answer a question or we run out of time, we are going to take all of the questions that are posted to us throughout the whole session. And following the session, we're going to put together a digest of questions and answers, and we will send this out to all of you who have registered. So any questions that we're not able to get to or we can't answer very quickly, we'll just push out via the digest afterward. And we hope to have that out by the end of the week. But it, of course, depends on how many questions you guys give us. So with that, let's move on. We're going to start off with an overview of meaningful use. We're going to go from a very high level. We're going to talk about, well, what is meaningful use? I like to use this slide. It's very succinctly and hopefully at a comedic level demonstrates very succinctly what meaningful use really is. Here we have, in our seasonal representation, we have snow, and we have the meaningful use of snow. So it's about taking your certified EHR technology, here the snow, and demonstrating that you can meaningfully use it, here represented by the snowman. And if you've already implemented an EHR, I have no doubt that at one point you felt as though you were being crushed by a January Michigan snowfall. It's not enough just to own a certified EHR. Providers have to demonstrate to CMS and or the state that they are using their EHR in ways that can positively impact the care of their patients. To do this, providers must meet all of the objectives established by CMS and the state for these programs. They will then be able to demonstrate meaningful use of their EHRs and receive an incentive payment. Simply put, meaningful use is using your EHR in a way that positively affects patient care. Ultimately, it's hoped that meaningful use compliance is going to result in those better clinical outcomes, improved population health outcomes, increased transparency and efficiency, empowered individuals, and push for more robust research data on health systems. To achieve this complex goal, the criteria for meaningful use is staged in 3 steps over the course of the next several years. Stage 1 sets the baseline for electronic data capture and information sharing. Stage 2, which starts in 2014, just around the corner, looks to push advanced clinical processes, and Stage 3, which doesn't start until 2016, and there's very little information known about it right now. This will continue to expand on this baseline. Each stage has its own set of requirements for meaningful use. Stage 2 focuses on advanced clinical procedures, including measures focused on more rigorous health information exchange, HIEs, additional requirements for e-prescribing and incorporating lab results, electronic transmission of patient care summaries across multiple settings, and increased patient and family engagement. Here we'll take a look at the meaningful use timeline. You can see the program started with Stage 1 back in 2011, and for anyone who jumped on board at its onset, you were in Stage 1 for 3 years. So you've been on Stage 1 through this year, and the earliest you can start Stage 2 for anyone is in 2014. And so here you see for anyone who started in 2012 and beyond, you're in Stage 1 for 2 years, Stage 2 for 2 years, and then on to Stage 3, which starts in 2016 at its earliest. There's some differences between the Medicare and the Medicaid programs, and we'll touch on those here. In the Medicare program, the incentive payment amount varies based on your fee-for-service allowable amounts. The maximum amount that you could have gotten over the 5 years of the program is $44,000. Although any payments made after April 1st of this year are reduced by 2% due to the mandatory federal sequestration that happened. The program requires 5 consecutive years. You cannot skip a year. So once you're in the program, you need to continue in the program through the 5 years. We'll talk a little bit about what that means if you're not able to consecutively be in it for the 5 years. Administered by CMS, and we have payment reductions that start in 2015 if you're an eligible provider in the Medicare program and you are not a meaningful user by the end of this year. So you've got very little time left if you're not already on board if you want to avoid those 2015 payment reductions. That is 1% starting in 2015, and it increases by 1% a year up to a maximum of 5% if you continue to not be a meaningful user and are a Medicare provider. We'll go into a little more in depth a little bit later in the program about what those payment reductions mean and how to avoid them. Medicaid program, a little bit different here. It requires at least 30% of Medicaid patient visit volume, or 20% if you're a pediatrician, to be eligible to participate. So in the Medicare program, if you're a Medicare provider, you can be on board. In the Medicaid program, you have to have a pretty good number of Medicaid patients to participate. You can show this, your patient volume with your individual patient volume or by something called a group proxy, which averages patient volume across all providers. Another benefit to the group proxy, using the group proxy, which not only can leverage the different patient volumes. If you have a provider in your practice who has a very high Medicaid patient volume and maybe somebody else who is only seeing 10 or 15%, you can average your patient volume across the practice, which would give everybody the ability to participate at that 30% or 20% if you're a pediatrician level. The other great thing about the group proxy is you're able to count nurse visits in that as well. So it's another way to help boost your Medicaid patient volume to make you eligible for the program. The program also allows for mid-level providers to be included, so nurse practitioners, for example. You've got a maximum of $63,750, so significantly more than the Medicare program, and this is over 6 years of participation. You can skip years, and it doesn't mean that you can skip stages or really skip parts of the program. It really means that you can take a year off. If for some reason you've got some extenuating circumstance, let's say your Medicaid patient volume drops below that 30%, you're not going to get dinged in the program. You can kick back in neutral, take the year off, and then start back up where you left off in the next year if you're able to overcome whatever it was that caused you to need to take a year off. This is administered by the state Medicaid agencies. So for us, it's the Michigan Department of Community Health. No Medicaid payment reductions if you're not a participating provider. So the payment reductions we'll talk about a little bit later are on the Medicare program only. And in this first year, there's something called Adopt, Implement, and Upgrade, or we call it AIU for short. So in that first year, you get a very large payment. It's $21,000 and change, just for either adopting, which means you're purchasing access to a certified EHR, you're implementing, meaning you're beginning to use your certified EHR, or even just upgrading your existing EHR to the new certified version. If you go through the AIU portion and prove that you've met the requirements, you get that first EIU payment of $21,000 and change, which we'll touch on a little bit more later as well. I'm going to go on to the Medicare payment schedule for EPs. You can see if you jumped on board back in 2011 or even 2012 where you were at. If you're a little behind the game and are just getting on the program in 2013, not to worry. You can still still be in the program. However, your maximum payment has reduced significantly from the beginning of the program. And again, if you're not on board and you take another year off and don't start until next year, you can see on the left-hand side of this grid that you're going to lose about $15,000 per provider again. So there's definitely an incentive to get on board and get on board quickly. Medicaid incentive payments. This grid looks a lot different. There's no real variations in that payment. Again, in year one, you get that AIU payment of $21,250, and each subsequent year of the program that you participate is another $8,500. Again, it does not have to be consecutive as it did in the Medicare program. You can take a year off and jump back on and pick up wherever you left off and pick up on those incentive payments again. EHR incentive programs stats to date. We have approximately 83% of all eligible hospitals have received an EHR payment for either attaining meaningful use or for that first AIU hurdle. But 1 out of every 2 Medicare eligible professionals are meaningful users of EHRs. 3 out of every 4 Medicaid EPs have received an EHR incentive payment. 3 out of every 5 Medicare and Medicaid EPs have made a financial commitment to an EHR, and over 325,000 Medicare and Medicaid EPs across the country have received an EHR incentive payment to date. So who is achieving meaningful use? So I know a lot of folks out there think this is just for primary care. This slide indicates that we have a wide spectrum of medical specialties that are involved in the meaningful use program. And really, 61% of all the Medicare EPs who are meaningful users are actually non-primary care. And incidentally, there's some new legislation that's just recently been introduced into our government to expand the Medicare program even further and start to wrap in some of the behavioral health folks into the program as well. So stay tuned if you're in that specialty and are looking to get on board. With any luck, that'll be expanding to include you soon. The National EHR Incentive Program to date, we have almost 146,000 providers have signed up with a regional extension center. That's who we are. MCEDA is one of the regional extension centers. I'll explain that program a little bit more near the end of the program as well. But that's what REC stands for. That's MCEDA. That's one of us. We have about 118,000 regional extension center providers are live on an EHR. Just over 55,000 of those have demonstrated meaningful use across the country, and a staggering $12.5 billion have already been paid out to eligible providers under these programs. Let's scale that down to Michigan and take a look at just what's happening in our state. As you can see under the Medicaid program, we have quite a few people have attained that AIU, that very first payment, and we've paid out about $133 million under that. We've got an additional group of folks that have attained meaningful use under the Medicaid program, and we've paid out just shy of $44 million. And on the Medicare side, we've got thousands of providers that have attained meaningful use in Michigan, and we've paid out. The state has paid out, the federal government has paid out in the Medicaid program a whopping $135 million there as well. So lots of movement in these programs. All right, from here, let's get a little more in-depth into Stage 2 and show you some of the nuts and bolts about what's happening and some of the differences between Stage 1 and Stage 2. We'll go through those summary of objectives and measures. and let you know what you need to do to continue to be a meaningful user or to attain meaningful use under Stage 2. So what does this mean to you? Well, there's a whole lot of new criteria starting in 2014. And Stage 2 includes new objectives to improve patient care through better clinical decision support, care coordination, and patient engagement. And it's all about saving time, saving money, and most importantly, saving lives. And really, that's not just Stage 2. That's the entire Meaningful Use program is designed for this kind of triple aim of saving time, money, and lives. The general structure going from Stage 1 to Stage 2 hasn't changed a great deal, although one thing that has changed is the total number of objectives. In Stage 1, you worked on 13 core objectives and got to choose 5 out of 10 menu objectives for a total of 18 objectives. In Stage 2, that changes just slightly. We've got 17 core objectives that everyone has to hit. You get to pick 3 out of 6 menu objectives, and for a total of 20 objectives to become a meaningful user. One question we get a lot is, do I need to upgrade my EHR? In 2014, the answer is yes, most likely. Due to the increased requirements of Stage 2, which we'll get into that in a little bit in some of the slides, the EHRs have had to undergo a pretty vast expansion of capabilities, and that has required them all the vendors to go back and need to become recertified under new 2014 standards. So if you attain meaningful use and you are on an older version, you haven't done much with your EHR, chances are you will have to upgrade your EHR in order to stay on the meaningful use path and to attain Stage 2 of meaningful use. So even if you already have a certified EHR, you're going to need to adopt or upgrade to new certifications to begin to participate. And then another thing to note is because of this need that everyone's going to have to go through to upgrade, they've changed the reporting period in 2014 to help offset this, to give providers time to get that upgrade done. So in 2014, regardless of the stage or the year you're in, whether you're in Stage 1, Stage 2, it doesn't matter. You only have to demonstrate meaningful use for a 3-month period in 2014. There's a little caveat here that you really need to be aware of, though, is that Medicare-eligible professionals beyond their first year of meaningful use, which incidentally is quite a few of the folks that are on the line today, you must select a 3-month reporting period that's fixed to the calendar quarter. And so you're looking at those calendar quarters and picking that 90-day window if you are beyond your first year of meaningful use. If you are in your first year of meaningful use in the Medicare program, you can select any 90-day reporting period. Doesn't matter. As long as it's in the 2014 year, you can pick any consecutive 90-day reporting period. Same for Medicaid. So you can choose, regardless of where you're at in the program, you can choose a 90-day reporting period that falls within the 2014 calendar year. But again, if you're in the Medicare program and you are beyond your first year, that 90-day reporting period has to be fixed to the calendar quarter. So what are the Stage 2 objectives? So again, we have those 17 core objectives plus 3 menu measures. You add in the clinical quality measures, or CQMs, which I'll expand upon a little bit later in the program. Doing those 3 things gets you to Stage 2 of meaningful use. Many of the objectives in Stage 2 will be familiar to you from Stage 1. Some objectives that were in the menu set in Stage 1 have been moved to the core set for Stage 2 and are now required for all providers. Some objectives that were in the core set in Stage 1 now have higher thresholds that you must achieve in order to successfully demonstrate meaningful use of your EHR in Stage 2. There are also some new Stage 2 core and menu objectives. Keep in mind that this is only an overview. Over the next several slides, I'm going to be going over each of the objectives, and we'll be taking a quick look at them so you can get an idea of what the objective requires, as well as what the exclusions are if they exist for the objective. But this is only an overview. There are many details about meeting these objectives that cannot be addressed here. Once you have a grasp of the Stage 2 basics, I encourage you to explore the Stage 2 Meaningful Use specification sheets found on the CMS website, which give an in-depth information on each of the objectives, including how to calculate numerators and denominators, definitions of important terms, and additional information about achieving the objectives. You can go to the CMS site, which is www.cms.gov, navigate to the EHR incentive programs, and there is a wealth of information there. And if you are an MCEDA client, we would be happy to help you kind of navigate through this and answer any questions or anything you might have as well. All right, here we have the 17 core objectives that are listed. I'm not going to go through and read all these, but for the next 17 slides, we're going to touch on each one of these briefly and give you just a brief overview of what's needed for each one of these objectives. On to the first one, computerized provider order entry, CPOE. So in stage 1, this measure was only for 30% of meds. Stage 2 increases the threshold to 60%, as well as adds labs and radiology to the mix. You need 30% of each of these. One thing I did want to note here also, there was a change that happened in the beginning of this year, actually, previously, the only folks that were able to participate in this measure, or the information needed to be entered by the physicians or the nurses, the licensed healthcare professionals. There was a change made that came live on January 1st of this year that also wrapped certified medical assistants into this. So they are now also able to enter the CPOE and have this information count towards meeting this measure. But you need to make sure that if you have medical assistants entering your meds, your labs, your radiology, that if you intend to have those counted in this measure, that your medical assistants are certified. They need to go through the additional certification qualifications and get that extra credential added to be CMAs and not just MAs. E-prescribing. Stage 2 increases this threshold from 40% to 50% and adds the additional requirement that this 50% needs to be compared to at least one drug formulary as well. So no phone, no fax, electronically transmitted directly from your EHR. And you can be excluded from meeting this objective if you write fewer than 100 prescriptions during the reporting period, or if you do not have a pharmacy in your organization, nor a pharmacy that can accept electronic prescriptions within 10 miles of your practice location. Recording demographics. Again, the only change for this measure between stage 1 and stage 2 was in the threshold. It increased from 50% in stage 1 to 80% in stage 2. There are no exclusions on this one, so everyone must meet this objective. You need to be recording in your EHR the preferred language, gender, race, ethnicity, and date of birth. Recording vital signs. In stage 1 measure indicated 50% of patients age 2 and over have height, weight, and BP recorded. The new stage 2 measure increases the threshold to 80%, but changes BP to age 3 and older, and there is no longer an age restriction for height and weight. And you can be excluded from recording all 3 vital signs if you don't think these are relevant to your scope of practice. You can also be excluded from recording just blood pressure if you don't believe blood pressure is relevant to what you're doing in your office. Or you can also be excluded from just the height and weight requirement if you don't believe either one of those are relevant to you either. And you can also be excluded from recording blood pressure if you see no patients age 3 or older. Record smoking status for patients 13 years and older. For this one, the only change is again with the threshold. It increased from 50% in stage 1 to now 80% in stage 2. And you can only be excluded from this measure if you do not see any patients 13 years old or older. Clinical decision support, CDS. So these requirements increase significantly in stage 2. In stage 1, you only needed to implement 1 clinical decision support rule. In stage 2, you'll need to implement 5 that are related to 4 or more clinical quality measures, as well as ensure that your drug-drug and drug allergy checks are enabled in your EHR. The drug interaction checks was actually its own core objective in stage 1, but in stage 2, this requirement has been included in the CDS objective. There's no exclusion for this first objective, so everyone's got to meet it. However, you can be excluded from the second measure with having the drug allergy checks, those drug interaction checks enabled if you write fewer than 100 medication orders during the reporting period. Provide patients the ability to view online, download, and transmit their health information. This next measure has also significantly expanded in Stage 2. In Stage 1, more than 50% of all patients who requested an electronic copy of the record were provided it within 3 business days. Now in Stage 2, this has changed to providing 50% online access, and not just electronic, but actually online access within 4 business days, like through a patient portal. And you'll need to show that more than 5%. For this exclusion, if you go to the CMS website, cms.gov. And again, if you're part of MCEDA, we'd be happy to help you with that as well. Next measure, provide clinical summaries for patients for each office visit. For this measure, the threshold has stayed at 50% of patients, just like in Stage 1. However, the time frame has been reduced in Stage 2 from providing the summary within 3 days down to 1 business day. So you still got to hit the 50% of patients, but you got to get it to them faster. And you can only be excluded from this one if you do not conduct any office visits. Protecting electronic health information. This is really one of the only objectives that didn't change at all between Stage 1 and Stage 2. Everyone must conduct or review an SRA, and again, there are no exclusions. We've got to make sure that you're doing a good job of looking at your systems, making sure that there are no security risks, doing that SRA to identify those risks, and then taking steps to ensure that you're mitigating those risks and fixing those holes and protecting that health information. Incorporate clinical lab test results into certified EHR technology. Lab results are a new objective for Stage 2. Did not see this one in Stage 1. In here, 55% of lab tests ordered during your reporting period must be recorded in your EHR as structured data. You can be excluded from this objective if you did not order any lab tests during the reporting period, or if none of the results from the tests you ordered come back as a number or as a positive or negative response. Generate lists of patients by specific conditions. This measure moved from an optional menu item in Stage 1 to a core objective in Stage 2. You get to decide what condition is clinically relevant or useful to you, and then generate a report from your EHR of patients with that condition. Not a tough one in my opinion, and there are no exclusions. Everyone's got to meet this particular objective. Identify patients who should receive reminders for preventative or follow-up care. This is another measure that moved from menu in Stage 1 to core in Stage 2. This measure has also undergone a significant overhaul. In the Stage 1 measure, more than 20% of all patients aged 65 years or older or 5 years old and younger were sent an appropriate reminder during the EHR reporting period. Now in Stage 2, we're targeting patients who have more frequent contact with you. So over 10% of patients with 2 or more office visits within the last 24 months need to be sent a reminder. This reminder should be sent by whatever the patient's preference is of the communication methods that you have available to them. This could be by regular old snail mail, individual phone calls, automated system phone calls, or perhaps some other form of secure electronic communication, like through your patient portal. Oh, and again, you can only be excluded from this measure if you had no office visits in the 24 months prior to the reporting period. Identify patient-specific education resources and provide these resources to the patient. So the only change to this measure in Stage 2 was to change from a menu objective that you could choose to do to a core objective that you must now do in Stage 2. The ability to recommend educational resources to your patients with the help of your EHR is one of the certification requirements that dictates your EHR upgrade that we discussed earlier. So if you've got an EHR that's been certified, it has the ability to provide these, to suggest education resources to your patients. And you need to do that for more than 10% of those patients. Perform medication reconciliation. Again, for this measure, the only change was to move it from the optional menu objective to a mandatory core objective. For more than 50% of patients transitioned into your care, you must perform a medication reconciliation comparing the med list you received from the patient, hospital, or other provider against the information in your own EHR. And you can only be excluded from meeting this objective if you did not see any patients after they received care from another provider. Provide summary of care record for each transition of care or referral. This one, at least on paper, is pretty big. As you can see, this one's going to expand onto a second slide. We can only fit what this measure requires on this slide. We'll bump to the next one to get some more information. But again, this measure moved from menu in stage 1 to core in stage 2. The requirements are also now expanded in this measure. Under stage 1, only measure 1 was included, which indicates that you must provide a summary of care record for more than 50% of transitions of care and referrals. As you can see, there are now 2 additional measure requirements for this objective. In measure 2, 10% of these must be electronically transmitted via your EHR or through an eHealth exchange participant, like an HIE. Additionally, in the third part of this measure, either one or more of these exchanges must be with a recipient who has a different EHR system than you, or you must conduct one or more successful tests with the CMS-designated test EHR during your reporting period. So in summary, over half of the patients that you refer to another provider or transfer to another care setting, you need to send that next care provider via either electronic or paper a summary of care document that's generated directly from your EHR. And then of those, at least 10% of them must be sent electronically. And then of those, at least one of them has to be sent electronically to someone who has a completely different EHR than you. And if you don't do that, you can also use the designated CMS test EMR to prove that you're able to do that. So again, here it's just about it's ensuring that you're not only able to communicate to an EHR that's the same as yours, but you can cross those barriers and start to communicate with providers who have different EHRs. Because let me tell you, there are a lot of them out there. You can only be excluded from all 3 of these measures if you transfer a patient to another setting or refer a patient to another provider less than 100 times during your reporting period. Lots of hoops to jump through on this one measure. Submit electronic data to immunization registries. As part of the new 2014 certification criteria, your EHR will come equipped with the ability to electronically send immunization data. In stage 1, you had the option to test your EHR's ability to electronically transmit this information to a public health registry. In our state, that would be MICR. Now in stage 2, successful transmission of this data on a continuing basis is mandatory unless you're excluded for one of the reasons listed above. And I'm not going to go through all these, but it basically, if there isn't a registry available, the registry is available but is not capable of accepting information, if they're not able to give you timely information, or if they're just not able to enroll you, you can be excluded from this measure. Use secure electronic messaging to communicate with patients. There is no change to this measure moving into stage 2. As was the case in stage 1, to meet this measure, more than 5% of unique patients must reach out to you via your certified EHR technology. And you can only be excluded from this measure for one of 2 reasons. If you have no office visits during the reporting period, or if, again, you're in an area with low broadband availability, you can get out of this one too. All right, those are the core objectives. We're going to move on to the 6 menu objectives. We'll do the same thing, go through each one of these briefly, and tell you what each one of them entails. 5 out of 6 of these stage 2 menu measures are new from stage 1. Syndromic surveillance is the only recurring objective, but even that one has changed. So the question comes up, what if none of the menu objectives are relevant to your scope of practice? Well, it's rare, but it's possible that none of the menu objectives are applicable to your scope of practice. If that is the case for you, and you qualify for all of the exclusions for each of the menu objectives, then you can select 3 menu objectives and claim the exclusion for each. However, if you do not qualify for all of the exclusions to the menu objectives, you must go back and select menu objectives on which you can report. So you can't just look through these 6, pick 3 that you qualify for the exclusions, and then claim those. You need to look at all 6 and decide if you qualify for any of them, you must choose that one. All right, submit electronic syndromic surveillance data to public health agencies. In stage 1, the objective was simply to test your EHR's ability to electronically transmit the syndromic surveillance data. In stage 2, this objective expands to include submitting this information, for example, data on patients presenting with complaints of flu-like symptoms, a continuing basis for the entire reporting period. We've got some exclusions here as well. If you're not in a category of providers that collects ambulatory syndromic surveillance information, or you've got some other issues in your jurisdiction where you're not able to submit this information to the public health agency, for whatever reason, you can be excluded. So this one is about, it has nothing to do with labs. This is really looking at very, very, very basic information, kind of that chief complaint that your patients are presenting with. You'll be sending this information onto the state and onto the CDS. It helps to alert them to pockets or if there's problems erupting. Let's say we're coming into flu season right now, so they keep an eye on this syndromic surveillance information to help them very early detect where there are pockets of, let's say, flu that are erupting. It helps them manage this population. That's what the syndromic surveillance is all about. It has nothing to do with submitting labs. It has nothing to do with submitting any patient identifiable information. It's just about sending the kind of chief complaints on. Record electronic notes in patient records. This one is a new measure for stage 2 and is fairly straightforward. If you select this menu measure, you will need to enter progress notes into your EHR for over 30% of unique patients with at least one office visit during the reporting period. Note that these progress notes must be created, edited, and signed by an eligible professional. For anyone that's using a scribe to generate progress notes, this could cause a big problem for you. This measure also has no exclusions. Imaging results accessible through your certified electronic health, your certified EHR technology. Another new addition to stage 2. For over 10% of all tests that yield an image, the test results must be accessible through your EHR. This means either stored directly in the EHR or via a direct link in the EHR to another system, like PACS. You can claim an exclusion on this measure if, during the reporting period, you order less than 100 tests that yield an image or don't have access to electronic imaging results at the start of the reporting period. Record patient family health history. For this optional measure, you must record family health history for over 20% of your patients, and this history must include one or more first-degree relatives. You can only claim an exclusion on this measure if you have no office visits during the reporting period. Report cancer cases to a Public Health Central Cancer Registry. As part of the 2014 EHR certification, in stage 2, your EHR, by default, will have the ability to electronically submit cancer case info to a Public Health Center Cancer Registry. For this measure, you must successfully submit this info electronically for the entire reporting period. And there are 4 possible exclusions for this measure. Again, if you do not diagnose or directly treat cancer, or if you've got those jurisdictional problems again that we've seen similarly on some of the other measures, where your public health agency just can't receive your information, if they can't give you the information you need to be able to send them the information, or if they're just not able for whatever reason to get you signed up right now, you can be excluded from this measure. And finally, the last measure is the report specific cases to a specialized registry. This objective is very similar to the previous one involving cancer, only in this measure you're choosing another disease state that's relevant to your practice and submitting data to a specialized registry associated with that specific disease. And likewise, there are exclusions for this measure, and they are almost identical to the exclusions on the previous measure. Where again, if you're just not able to, for whatever reason, to send this specialized registry information up. All right, we're going to move on to the clinical quality measures, the CQMs. In 2014, CQM reporting changes for everyone, regardless of what stage and year you're in. So it doesn't matter if you're just beginning the program, if you're in stage 1 or stage 2, the changes in 2014 apply to everybody. If you are a Medicare eligible professional in or beyond your second year, you must submit CQM data to CMS electronically. You no longer have that ability to submit it in paper. It's got to be, if you're in or beyond your second year, it's got to be electronic. And then in the Medicaid EHR program, participants will submit their CQM data to the state Medicaid agency, which again is the Michigan Department of Community Health. Beginning in 2014, eligible professionals must select and report on 9 of a possible list of 64 approved CQMs for the EHR incentive programs. There's also a new requirement in 2014 that the quality measures selected must cover at least 3 of the 6 available NQS, National Quality Strategy domains, which represent the Department of Health and Human Services, the HHS's NQS priorities for healthcare quality improvement. I've got those 6 here listed: the patient and family engagement, patient safety, care coordination, populations and public health, efficient use of healthcare resources, and clinical processes effectiveness are the 6 buckets. So you see, prior to this year, you were reporting 6 out of a possible 44 CQMs, where you had 3 core or alternate core and then 3 menu objectives that you could choose from. In 2014, it changes significantly. You've got to report on 9 out of a possible 64 choices. And the ones that you choose, you have to make sure that you're hitting at least 3 of the 6 domains that are listed here. And CMS actually has issued some recommendations for CQMs. They give us 9 recommended adult CQMs and 9 recommended pediatric CQMs. I'm going to go through those in just a couple of slides, and not go through them in any great detail, but I'm going to pull up the slides that show you what those 9 are for each, just to give you a flavor for what the CQMs entail in 2014. So we've got the 64 possible measures from which you need to choose 9 to report. They cover a wide range from pediatric and adolescent measures, diabetes measures, screening measures for adults, asthma, immunization measures, osteoarthritis, heart failure, you name it. We've got many, many, many choices to fit every scope of practice. So out of those 64, you're going to be able to find something that applies to your practice. Here we've got the first 4 of the recommended adult measures. So we're choosing from controlling high blood pressure, the use of high-risk medications for the elderly, imaging studies for low back pain. Here's the next 5 on the recommended adult CQMs. We're looking at preventative care and screening, the BMI screening and follow-up, receipt of a specialist report. We're looking at making sure that we're documenting the current medications in the medical record. Pediatric measures. We've got the first 4 of 9 listed here. The recommended ones anyway, although again, you've got 64 to choose from. We're looking at chlamydia screening for women, using appropriate medications for asthma, weight assessment and counseling, nutrition. Next 5, childhood immunization status, looking at ADHD, the clinical depression follow-up, screening and follow-up plan. Even looking at children who have dental decay or cavities. So again, these are only the recommended CQMs. You've got a lot to choose from, and you need to choose 9. So that kind of wraps up some of the objectives and measures under Stage 2. I want to talk for a little bit about payment adjustments and audits. So what does it mean if you're a Medicare provider and are not a meaningful user as of 2013? We'll also talk a little bit about the audits. What's going on at the state and federal level to double check all of the meaningful use work and make sure that T's are crossed and I's are dotted. Medicare payment adjustments under the HITECH Act, it's stipulated that that payment adjustments apply to any eligible professionals, eligible hospitals, and critical access hospitals who do not become meaningful users. And I do want to note here that a provider who is in the Medicaid program and has gotten that very first payment, that AIU, that adopt, implement, or upgrade, that does not qualify you as a meaningful user. So if you are a Medicare provider, you are in the Medicaid program, and have only received that very first payment under AIU, you will still be subject to the payment adjustments because you have not attained meaningful use. So very important thing to note. Payment adjustments on the timeline. You can see here that to avoid that the the payment adjustment in 2015. If you were a meaningful user in 2011, 2012, or 2013, you've got to achieve meaningful use this year, or you will be subject to payment adjustments starting in 2015. And you must continue to demonstrate meaningful use every year to avoid the payment adjustments in subsequent years. So again, you need to get on the bandwagon. You need to be a meaningful user this year, 2013. Otherwise, you will be subject to a 1% reimbursement reduction in 2015. It starts out at 1% and will increase an additional percent up to a maximum of 5% if you continue to not be a meaningful user and are a Medicare provider. How do you avoid the 2015 payment adjustments? So again, from a very specific calendar level, if you were a meaningful EHR user in 2011 or 2012, you need to end your reporting period by December 13th of this year, and you need to attest to meaningful use by February 28th of 2014. If you do not, you will be subject to those 2015 payment adjustments. If you've never been a meaningful EHR user, and again are a Medicare provider, you need to end your EHR reporting period by September 30th of next year, and you need to attest by October 1st, the very next day, in 2014. If you do not, you will again be subject to those payment adjustments starting in 2015. And you can apply to CMS for a hardship exemption by July 1st, 2014. So there's a few conditions here that I'll touch on that can get you out of that if you happen to qualify. There are 5 reasons where you could not be a meaningful user and still avoid those the payment adjustments. One is for infrastructure. If you can demonstrate that you're in an area without sufficient internet access, that whole broadband availability that we talked about before, or if there's some sort of insurmountable barriers that mean you can't have the technology that you need. New EPs, if you're just a new physician and you haven't had time to become a meaningful user yet, you can apply for a 2-year limited exception to the payment adjustment. Unforeseen circumstances. I sure hope none of you are in this boat, but if for some reason you've been the subject of some sort of natural disaster, your practice burned down, again, I really hope and pray none of you have to use this one, but it's there if you need it. You can also get out of the payment adjustments if you can demonstrate a lack of face-to-face or telemedicine interaction, or have a lack of follow-up need with your patients. And finally, if you practice at multiple locations and have a lack of control at a location that you see more than 50% of your patients, you can apply for a hardship exception. So if you see a lot of your patients in the hospital, you also have a private practice but are seeing more than 50% of your patients in the hospital, and obviously you're not in charge of the hospital technology and cannot force them to implement the technology you need to become a meaningful user, you can apply for the hardship exception here as well. Applying for the exception, 2 things I wanted to point here is the deadlines. That the applications for the exception need to be submitted no later than April 1st for hospitals or July 1st for EPs of the year before the payment adjustment year. And for more information on how to apply, you again can go to the cms.gov website. And if you are a part of the MCEDA team, you can, of course, call on your rep within CEDA, and we'd be happy to help you out with this as well. Incentive payment audits. So anyone participating in either EHR incentive program is subject to an audit. CMS is handling audits on Medicare and dually eligible providers, and the state of Michigan is performing audits on Medicaid providers. The audit strategy includes 4 parts, starting with a primary risk assessment that identifies high-risk areas, a data audit logic check, and a data validation approach that look for variations in data entered to identify potential issues and outliers that could signify the need for an audit, and an alternate logic-based strategy that compares just the data you've submitted to look for aberrations. Since many of the measures use the same or related numerators and or denominators, if this, then that type questions can be applied to the data you submit to look for potential problems. Long and short, don't try and game the system. You're going to get caught. Post-payment audits began in 2012, and CMS began prepayment audits in 2013, beginning with attestations submitted in 2013. If you're selected for an audit, you'll be required to submit supporting documentation to validate your information. And regarding that documentation, you must retain all attestation supporting documentation in either paper or electronic format for 6 years from the date of attestation. In our experience, this often involves capturing screenshots as proof of meeting objective measures, as well as printing reports, etc., right from your EHR. Essentially, if you used it to attest, find a way to save the information in case you're audited. It would be a shame to successfully complete a measure, but then fail an audit simply because you failed to save the proof you need to show you were successful. And the audits are all or nothing. So if you fail to provide proof on any one measure, your entire attestation is at risk, and you would lose the entire incentive payment, not just a portion for that one measure. Some of the most common audit issues that we're seeing: the drug and drug allergy checks, and the drug formulary checks, indicating that you have those enabled, but you actually don't. We see issues, and the state and federal governments are seeing issues in these audits of folks that are claiming the exclusion for verifying that they write less than 100 scripts, but then not been able to back up that with the proof. Another common audit issue is the TDS support rule is not enabled, and claiming that it was. No proof of the exchange of key clinical information. Submission of electronic data to the immunization registries, again, having no proof of having done that. Not conducting your security and risk assessment, your SRA, so saying that you've done it but didn't. And there's also some issues with that group proxy that I talked about. So again, leveraging your patient population across all providers, kind of averaging across all providers to get everyone to that 30% or 20% if you're pediatrician level. In doing that, but then not being able to back that up and prove that you were eligible to be a Medicaid participant using group proxy. Those are all the common audit issues. All right, from here, I'm going to touch a little bit about MCEDA and kind of give you a brief program overview. Again, we have a pretty good mix of folks on the line of folks that are current MCEDA clients, as well as a host of people that are not yet signed up with MCEDA. And I'm going to touch a little bit about what we are, who we are, what we do, and I think for even those who are current MCEDA clients, you might see a little something in here about some additional services that we can provide to you. So MCEDA, the Michigan Center for Effective IT Adoption, we are one of 62 regional extension centers that were set up under ARRA, under the American Recovery and Reinvestment Act of 2009. We are subsidized by the federal government to build awareness and accelerate the adoption, implementation, and effective use of electronic health records. We are the 8th largest REC in the country, and these services are actually provided under 4 different organizations. There's 4 of us that come together to form MCEDA. Alterum Institute, which is where I'm speaking to you from today, we are the home of MCEDA, but we are helped out with 3 other organizations that come together to form MCEDA. They are a tremendous help to us across the state. We have the Michigan Public Health Institute, MPRO, and the Upper Peninsula Healthcare Network. So the 4 of us have come together to form MCEDA, and our program is subsidized by the state and federal governments. So in most cases, our work to help you effectively use your EHR and achieve meaningful use comes at an extraordinarily low cost, and in some cases is even free to you. So the state and federal governments pay us to help you. We have a host of expertise, tools, and reference materials designed to cover the entire spectrum of EHR adoption, from engagement, selection, and planning, to the health IT implementation, and finally achieving meaningful use. And this slide not only reiterates information on what could be called our meaningful use or perhaps EHR services, but I want to bring to your attention that we are also experts in workflow redesign and offer something called Targeted Process Optimization, or TPO. And this is a service that leverages lean principles and tools to streamline key clinical processes like chart prep, order tracking, or perhaps referrals management. This is a service that you can use to target specific practice problems without incurring the time and expense of traditional lean deployment. So from our federal and state subsidized programs to our fee-for-service offerings, if you're not covered in one of those subsidized programs, MCEDA has a solution to meet your needs. And our progress so far. This last slide, I just want to show that to date, we have over 4,000 providers across the state of Michigan have enrolled with MCEDA for support. More than 3,500 of these providers are live on an EHR, either with our help or without. Over 2,100 providers of these providers have achieved meaningful use, and the vast majority of the rest are well on their way. And the latest survey shows that 96% of MCEDA customers are satisfied with the services that they're providing from us. And not only that, practices working with a regional extension center are twice as likely to be awarded an incentive payment. That's not coming from us. That's coming from the U.S. Government Accountability Office. From there, I want to thank you very much for attending this webinar and learning a little bit more about the Meaningful Use program in Stage 2. And I want to open things up to questions. I see we've had a couple of questions that have come in. I'm going to turn things back over to Leslie and Judy to answer your questions. So thank you.
Okay, a couple of questions received so far. People are asking about where they can get a copy of the PowerPoint.
So we will be, we have recorded this session. We will be posting both the recording of the session as well as a PDF version of the PowerPoint slides on the MCEDA website. We hope to have that up by the end of the week and hopefully sooner. So just check back at the MCEDA website the next couple of days, and we'll have that up for you.
Okay. Another question about avoiding the 2015 payment adjustments from Medicare. You can avoid the 2015 adjustments with your 2013 meaningful use activity. So if 2013 is your first year of meaningful use, 90 days of meaningful use demonstrated would avoid the 2015 adjustments. If 2013 is your second year of Stage 1 or possibly your third year of Stage 1, your reporting period would be 365 days, so January 1st to December 31st. Showing meaningful use in that reporting period would avoid the 2015 payment adjustments.
All right, great, thank you. It looks like that is it for the questions thus far. I mean, we'll give a few seconds if anyone else has any other questions you want to put into the question box on your web interface. And we'll give another minute here for any last-minute questions. If nothing else comes in, we'll wrap up and thank you guys all again for attending. And I do want to point out that this again is the first webinar in a new monthly series that we have that we're started here at MCEDA. So we are targeting these for the first Wednesday of every month, although in January, that first Wednesday is actually January 1st, so we're not going to do that. So we're going to, in January, we'll roll to the following Wednesday. So Wednesday, January 8th, we'll be holding another webinar. And Leslie, I think we know what this webinar will be on.
Yes, actually we'll be touching on patient engagement. Bobby Kalunai from our organization is going to be joining us and giving a really great presentation on, exactly what to do in Stage 2 with your patient portal, how to engage patients, and then just on a larger scale level, giving us an overview on the future of patient engagement and how that will play into meaningful use. Looks like we have a couple more questions, so I'm going to turn it back over to Bruce.
All right. Yep, we had one more question that popped in. Someone was asking for us to expand on the statement that most everyone will need a new EHR in 2014. It's not necessarily a new EHR, but it could be a new version of your current EHR. So in order to qualify for, in order to meet the objectives in Stage 2, the EHR vendors need to overcome some new certification requirements. They're all going back to CMS and applying for new certification for 2014, and as such, they are, yeah, I said CMS. They're going to the ONC for that certification. So in order to become a meaningful user under stage 2, you have to, your EHR that you have installed has to be certified under the 2014 version. And so if you have not already touched base with your current vendor, you're going to need to reach out to them and talk to them about their plans, or if they have already attained the new certification for 2014, and if not, if they're planning to. If they're not planning to, you're kind of in a tough spot where you may have to actually change your EHR in order to stay on the meaningful use path. But hopefully, I know a lot of them are working on that certification, and CMS nearly every day, I think, is posting new EHRs that have attained the 2014 certification. And again, you can also contact MCEDA. We'd be happy to help you figure out if you're certified, if your version is on the 2014 certified version. You can also reach out to your vendor, and they can help you with that as well. I think we had another question or two of them might have popped in. Moment we read through these. A host of questions coming in now, which is great. Appreciate you guys asking your questions. I have one question here. What happens if our EHR does not get the new certification for 2014? Will we get extra time to attest in 2014? So that was where I talked about how, regardless of the stage that you're in, whether you're in stage 1, stage 2, or no matter what year of stage 1 you're in, the requirements in 2014 have changed. So whereas if you were in a stage that normally would have required 365 days in your reporting period, in 2014, no matter what stage you're in, no matter what year you're in, you only have to attest for 90 days of meaningful use. They did this in 2014 specifically for this reason, to give you guys all the time that you needed, or some additional time anyway that you needed to make sure that your EHR is up to standards. Is up to that 2014 certification.
Bruce and Judy are just looking over a few more questions that have come in, and they'll be answering those shortly.
Some of these questions might require a little bit of research just to make sure that we answer it correctly as well. Worst thing we can do is pass on some misinformation to you. So if you posed a question, again, I mentioned this in the beginning, but for anyone coming in late, if you posed a question and we do not answer it here during the live broadcast, we are going to take all of these questions and put them into a digest with answers, and we will be sending these out to everybody who was in attendance today. And so regardless of whether it gets answered live or not, you will have your question answered via the digest, and we will email that out to you hopefully by the end of this week.
Additionally, we'll have the slides and the live recording posted on our website, mceda.org, in the resources section, which also has a whole host of other documents that we link out to that might be helpful in terms of your research as you're trying to achieve meaningful use.
I think we should put those in writing. A couple of the remaining questions are a little more involved, and I think it would be more appropriate for us to put a response in writing and share it with everybody. I think it would be an opportunity to provide a little more detail. So we appreciate the questions. They're excellent.
Definitely. And yeah, thank you for those ones that stump us a little bit and make us stay on our toes and even do some research on as well. We love those questions. Okay, so it looks like that's it. We haven't had anything come in for several minutes now. So with that, I think we'll wrap up. And again, we'll thank everyone very much for attending. We hope to see you again on our future webinars, and we hope you've gotten some great information out of this. If you have any other questions, comments, concerns, don't hesitate to reach out to us. We'd be happy to help. For anyone who is not an MCEDA client and is interested in finding out more, again, please reach out to us. We'll also reach out to you and get you any information that you need. So thank you all for attending. Thank Leslie and Judy as well for assisting. Hope you guys have a wonderful day.
Thank you. Bye.
Thank you.